Transforming care through genomic medicine, personalized therapeutics, health services and outcomes research, and innovations in healthcare delivery. We're Children's Mercy Kansas City, presenting our audio interview series, Transformational Pediatrics, with host Dr. Michael Smith.
Our topic today is new guidelines related to tick-borne infections. My guest is Dr. Mary Ann Jackson. Dr. Jackson is the Division Director of Infectious Disease at Children's Mercy. Dr. Jackson, welcome to the show.
Thank you so much. Good morning.
So I guess Children's Mercy has already seen some cases of tick-borne infections. Is this going to be a bad year?
Well, we think it is. I think mainly because we know that ticks survive with temperatures over 50 degrees, and when we have mild winters, we have ticks that are actually available all times of the year, but here we started seeing a lot of reports about ticks starting in March. We've already seen several children with tick-borne disease, including life-threatening tick-borne disease, so it's a good topic to talk about.
Yeah, and so, bringing it back to the community doctor, the primary care physician, the general pediatrician, what are some of the guidance you can give them for recognizing a tick-borne infection, and what are some of these new guidelines?
So in terms of recognizing tick-borne infection, in every febrile patient at this time of the year, we're asking physicians to ask about tick bites, but not only that, investigating whether or not their patient has had exposure to uncut grass, wooded or tick-infested areas, contact with dogs who may have had tick exposures, and travel to other high-risk areas. In addition to the Midwest, we see a high incidence of tick-borne diseases in North Carolina, Oklahoma, Tennessee, for instance, and remembering that the tick exposure may be in the patient's backyard or neighborhood and not necessarily down by the lake. And that also, clusters can happen within families, so inquiring about other symptoms in other family members.
Yeah, that's interesting, Dr. Jackson, because I think you're right. We tend to think of getting a tick, you're out camping, you're going on a vacation with the family, and you're going somewhere else, but yet your own backyard, even you mentioned your own dog. How often or how common is that for the pet to pass on a tick to a human?
Well, it's not uncommon, and think about the dog or the pet as being a surrogate marker of a tick-infested area. So in many cases, we hear from parents, in terms of the child that we're examining because of tick-borne symptomatology, they say, well, I don't remember taking a tick off this child, but we took a tick off the dog and the children play outside in the same area where the dog plays, or we've taken a tick off a sibling, or I found a tick on myself. So those pieces of information are exceedingly important.
Now, once the physician, is examining the patient, maybe there's a history of fever, some usually diagnostic tests are run. What's the problem with those tests, at least initially?
Well, it's a good point regarding testing. So first of all, we have the symptom onset, and it's usually fever, headache, vomiting, and muscle ache. And in that essence, it's very, very nonspecific. And while the rash of Rocky Mountain spotted fever, for instance, may develop, it can be absent in 20%. So we do have to think about diagnosis. Well, it turns out that the diagnostic testing for tick-borne diseases are not positive at the time of the patient's presentation. And so our recommendation is there are some testing that you can do in keeping the tick-borne infection in mind, including blood counts and liver function tests and electrolyte tests. But doing testing to look for antibody to Rocky Mountain spotted fever, rickettsia rickettsii, or to ehrlichiosis, Ehrlichia shaviensis, those should not be performed initially in terms of trying to make the diagnosis, and you should never delay therapy while waiting for those tick-related specialized tests to come back.
Dr. Jackson, is that a problem though? So are there a lot of physicians that aren't treating empirically, that they're waiting for those tests to come back? Is that a common scenario you find in the community?
I think that is a very common scenario. You now can find something called a tick panel. And so a physician may correctly suspect the diagnosis of a tick-borne infection based on exposure, based on clinical presentation. They may even have some of the basic laboratory studies there that are triggering those thoughts, including looking for blood count changes with low white counts, low platelet counts, low sodiums, or elevation in the liver transaminases. But they order something called a tick panel, and they think that is going to make the diagnosis. And truly, that is the mistake that we don't want to make. We should never order a tick panel and delay therapy waiting for that result, because that is not the way we're going to make our diagnosis. Acute serology is virtually always going to be negative, and you're waiting for the convalescent serology, meaning the antibody studies are not going to develop until later in the course, and that may be too late. So delaying therapy while waiting for those is not only common, but it is very detrimental to the patient. For Rocky Mountain Spotted Fever, for instance, we say for those children beyond 5 days of fever, and we know this happens quite often, that the child is initially thought to have a virus and then discharged and then comes back still febrile. At 5 days, children with Rocky Mountain Spotted Fever who look very benign at the beginning do not look benign at that point. They have clinically deteriorated and in many cases are requiring intensive care at that point.
Yeah. And so the empiric therapy is going to be doxycycline, correct? But does the age of the patient matter when it comes to doxycycline?
Doxycycline is the drug of choice no matter the age of the patient and should be initiated as soon as the diagnosis is clinically suspected. The past mantra has been tetracyclines can stain teeth, but it turns out that doxycycline does not, and we now have some good evidence that there's no evidence of dental staining, enamel hypoplasia, or any kind of tooth color differences, with some more recent information that occurred where many children were doxycycline exposed because of an outbreak of Rocky Mountain Spotted Fever, and we found no evidence of dental staining at all. So doxycycline is a drug of choice whether your patient is 4 months, 14 years, or 40 years of age.
Right. My guest is Dr. Mary Ann Jackson. She's the Division Director of Infectious Disease at Children's Mercy. So bottom line is we have to recognize the symptomatology. We have to act quickly on that with doxycycline regardless of the age. I'm going to change focus here just for a second, Dr. Jackson. You are also the editor of The Link, which is a monthly print and digital newsletter. Can you tell us a little bit about that?
Absolutely. The Link is a newsletter that we've published since 2009. It's distributed to pediatricians here locally, regionally, and across the United States. And the purpose is solely education. And we target 5 different themes within the Link. We target alerts, outbreaks, and hot topics. We target vaccine education for physicians. We look at evidence-based practices for common clinical questions that arise in community pediatric practice. We have a visual clinical vignette each month where a case that we've recently seen has occurred with a nice visual to go along with it, and physicians may actually test their own diagnostic skills based on the vignette. And we also have a state-of-the-art where we look at a common problem where physicians just may not have the time to update their knowledge about something they don't see very frequently. So we try to cover all the ballpark in trying to update information for physicians. It's short, it's structured, they can look at it at their own time frame. And we believe that we know it's very well received by physicians in our region. And in fact, tick-borne infection is something we covered earlier this season, a month or two ago, and we've gotten a lot of good feedback on that the pediatricians really appreciated having the information in a nutshell.
Yeah. Is there a website for The Link that you can share?
There is. It's www.childrensmercy.org, and then you just can search for the link, and it will pull it right up on the public
Gotcha.
site.
Okay. Gotcha. Well, Dr. Jackson, I want to thank you for all the work that you're doing. It sounds like you're going to be busy this time of the year, and thank you for coming on this show. You're listening to Transformational Pediatrics of Children's Mercy, Kansas City. For more information, you can go to childrensmercy.org. That's childrensmercy.org. I'm Dr. Mike Smith. Thanks for listening.